So I'm Sophia Albert. I'm the head of the Division of Adult Mental Health here in our department. I wear a lot of hats in the department, but probably the role I'm most excited about is being a clinical researcher. And so from that perspective, I'm thrilled to be introducing today Dr. Hamid Ekhtiyari. Dr. Ekhtiyari is a second-year resident in our adult psychiatry program. And although he's technically a trainee, he joined our department with an impressive list of accomplishments as a neuroscience researcher, even before electing to complete clinical training. His list of academic accomplishments is numerous and probably too numerous to do entirely justice to in this short introduction, but to name a few, he is the director of the International Network of Transcranial Electrical and Magnetic Stimulation Trials for Addiction Medicine. He's also the co-chair of the neuroscience section at the International Society for Addiction Medicine, and he also directs the Brain Awareness for Recovery initiative. I don't think it is hyperbolic at all to say that Dr. Ekhtiyari is truly an emerging leader who is going to reshape the future of addiction treatment and addiction medicine in general. As I was reflecting on experiences that I've had with Hamid, where I've been really impressed with him and sort of by all the sort of different aspects that he sort of brings to clinical research. The memory that sort of I kept coming back to was a dinner that we were having at the annual meeting of the American College of Neuropsychopharmacology. And this meeting, for those of you who aren't familiar, brings lots of sort of international leaders to sort of absorb more science in a day than really seems possible sometimes. And so typically at these dinners, we have a lot of chit chat about things that aren't necessarily science related. And this day, Dr. Ekhtiyari had led a symposium that included not only Dr. Nora Volkov, the head of NIDA, but also George Koob, the head of NIAAA. And despite this sort of full day for him, we were sitting across the table from each other, and he leaned across the table and he said to me, "Dr. Albert, what talk did you hear today that made you excited about the future of psychiatric research?" And it was just sort of crystallized in my mind that, Dr. Ekhtiyari is an exceptional scientist. He's an exceptional clinician as well, but probably his superpower is this ability to really catalyze enthusiasm in people that he talks science with. He sort of makes it almost infectious. So I am super thrilled to be introducing him today as he speaks about brain stimulation technologies and their treatment of addiction disorders. Dr. Ekhtiyari.
I'm gonna give you an idea about what are the new things that we have about brain stimulation addiction treatment. And for those who have not been able to hear us, I put all my slides in the QR code, so you can download the slides from the QR code, and I will provide you with kind of some other further details there. So my name is Hamid Ekhtiyari. I'm delighted to be here, and let's get started. Let's start with this question. How many FDA-approved applications that we have in the field of addiction medicine, addiction psychiatry for brain stimulation technologies? And you can use the chat space, and we can see the chat space to see how many responses we have right now.
Hasn't it been approved for smoking, or am I imagining that?
Oh, you're not that. Yeah,
It's the only one.
that's
Okay, so let's see how many responses that we have. We have one from Dr. Albert. Let's see what are the other responses that we have. And I can basically kind of expand the question towards the entire psychiatry. How many FDA approval do we already have for brain stimulation or non-invasive brain stimulation psychiatry in general so far? 3.
Depression, OCD, do count ECT,
that's 4. So yeah, ECT.
you're counting ECT, so mania,
Okay.
depression, OCD.
What else? Okay, so we'll get back to that. So that's a question just to kind of initiate the discussion. What are the approvals that we have? And then we can see how we can move forward and see what are the things that are going to be added recently. I do not have any conflict of interest. I have some funding from different sources. And before starting the presentation, I would like to thank those who supported me here in the University of Minnesota to be able to do the things that I'm doing right now and be able to move forward the research projects that I'm trying to perform. And meanwhile, people in Loyola Institute for Brain Research in Oklahoma who supported my my research so far. And I'm trying to see if I can use the clicker. Okay, and okay, so let's start with this slide. So it's 11 a.m. here, and we have a kind of nice dish of a nice brownie. And I'm not sure how much people would be interested to have a brownie like now, from 0 to 100. And I can just give you something like a visual scale kind of measure. And what would be your number from 0 to 100? Sophia.
That's a nice looking brownie. I don't know, maybe 60?
60?
Yeah.
0.
0, okay. 100. So in the room, we have different numbers right now. And I'm interested to know numbers from those who are online with us. I'm trying to see if I can see the chat space as well. So those who are online, we are interested to have your numbers as well. So we are going to have some of other questions like this. So I'm interested to have your contribution. So to see how many real people we have already online. So the numbers from basically from 0 to 100. What would be your number, your interest to have a brownie like this at 11 a.m. in the morning? Let's see if we have any responses. Okay,
People are going into the Q&A.
oh, they might be using the Q. Okay, so okay, now I can see that. Okay, now I can see the numbers. Okay, 80, 40. Okay, so we have different numbers. Okay, now I can see. Oh, the chat is still disabled. Okay, that's fine. So we have different numbers. This is what we call kind of cue-induced craving. So we have a cue, the cue can induce craving, and we can measure that. And it could be the cues that we have seen before, or it could be related to other cues. I was presenting in the kind of brain stimulation conference in Lisbon a few weeks ago, and other than kind of scientific works, we have been kind of going outside and trying different new things in Lisbon, and you probably can kind of recognize some of the faces that we had kind of together. We have been kind of trying different pastries in Lisbon. And one of the pastries that we really liked was this pastry. I'm not sure, have you ever seen this pastry? It's called pastel de nata. I'm not sure, have you ever tried pastel de nata? No? You have never tried. Okay, people here, they have never tried pastel de nata. I'm not sure if people here among the audience, they have ever tried pastel de nata. So it's an interesting egg yolk based pastry. It's crispy from outside, it's soft from inside. So it's an interesting sort of combination of different things. If I ask you how would be the level of craving that you have for pastel de nata, then people might have different responses. So you have never tried it, but you might have a sense how it might taste. So there might be different responses in terms of, there are people who say, okay, I've never tried, so I don't have any craving for it. But there might be people who say, okay, based on the shape, I might kind of have a sense how it is going to taste, and I can give you a number. So people can have different responses regarding that specific cue that they have never tried themselves. Okay, so there could be different levels of responses. We have similar kind of issues in terms of cues that could initiate appetitive or affective responses among people in different areas, including drug addiction. So in drug addiction, we can have cues that could initiate basically responses, appetitive responses or affective responses. And we still call that craving or cue-induced craving, okay? For us, we do not have any kind of experiences with cooking heroin and preparing heroin for injection. This cue could not initiate any craving. But for those who have background of injecting heroin, that cue is really effective in terms of inducing significant amount of craving. And I've shown these cues to patients who are kind of using heroin. And some of the times they just report as just disabling for them because the cues are so strong for them. Okay. And this is the way that we try to, in something like an experimental setting, assess the level of craving that people have. It's something like a challenge test that we're doing, for example, in cardiology. We put people in the challenge and then we measure their EKG, or we do an echo in terms of to see when they are in a stress, how would be their heart response to the stress. And we do this kind of similar things with those cues in brain imaging settings or in kind of clinical psychology or psychology experimental settings. And for being able to do that, we usually need to have database of drug cues. And we recently developed a large database for opioid and med cues. And this is what you can see here in the database. So we can have in this database, we already have 320 images that we can use in different settings, okay? So this is the way that we measure cue-induced craving. And in experimental settings, we can have control cues that we usually try to control for different conditions. For example, in these two cues, in both cues, you can see hands. You already have two hands. There are tools. So we try to see how we might be able to control different objects that we have in the cues. But the only difference between those two cues is the content in terms of the what is really happening, whether there is a drug-related activity or there is no drug-related activity. And we expose people to these drug and neutral cues, and we kind of measure how their brain would respond specifically to drug-related cues, and we can have brain activations. This is called what we call drug cue reactivity, or brain responses to drug-related cues. Okay, as you can imagine, there would be lots of different cognitive functions involved in this process.
A quick question, Hamid. Is this library of cues, has it been normed to people who have histories of addictions, and do they rate, are the cues sorted by intensity of the craving that they induce?
So what we did for the development of the database, we basically initially made several focus group discussions among different kind of people who have a history of substance use. So we developed the initial set, and then we asked another large group of people to rate those cues. And beyond that, we also have measured all the kind of psychophysics characteristics of the cues. And now when you select the cue, you have all those. So there's a large database. It's not like IAPS, but it's even kind of more extended than IAPS. So we have lots of kind of even psychophysical features of those cues. Yeah. And then all those things are publicly available right now. So I put all of them online so people can download them. And now there are over 20 labs around the world are using these drug cues that I'm aware of. So there would be probably more labs that are using the drug cues. Yeah.
So it's very analogous to IAPS, but it sounds like you've added in more of physical reactivity, psychophysical reactivity.
Exactly, and psychophysical features, and the database is larger, it's better controlled, and we have lots of controlled cues. So I would say it's a better quality in terms of the psychophysics features and the development process. Yeah. So, and then beyond that, we developed fMRI kind of drug cue reactivity tasks from that database. And now we are using that fMRI task to be able to activate kind of different brain circuits. And even those fMRI tasks and fMRI data is already available online. So we are providing those resources for those who are interested to work in this area. But what is interesting and important, this is one of the recent kind of meta-analysis that is being published in JAMA Psychiatry by Hedy Kober. And the interesting conclusion that she made at the end of that kind of meta-analysis in terms of drug cue and craving, she mentioned that based on what they have done and the kind of how drug cue reactivity could be predictor of relapse, they suggested that that should be incorporated to the assessment for every treatment that we have, because it's an important part of the response to treatment, and it's an important predictor of relapse. So drug cue reactivity is considered one of the core features of relapse to drug use. So it's important to see how we might be able to consider that in development of treatments. But when we expose people to drug-related cues, we have different brain circuits involved in kind of responses to drug cues. And the idea is there any chance that we can engage those neural circuits in the brain with different brain stimulation technologies that we have? And this is what I'm going to discuss today in terms of, is there any chance that we can modulate brain responses to drug-related cues? And by modulating that brain response to drug cues, we can prevent relapse, or we can prevent craving, because craving is one of the major kind of drivers of continued drug use and relapse. So that is the concept that we are trying to discuss today. And these are some of the what we call non-invasive brain stimulation technologies that we use. So we do not open the skull. We provide a kind of a little bit of energy, but we can stimulate different structures in the brain, and that would provide us with opportunities for modulating brain functions. And I will discuss about some of those technologies and how do they work in the field of addiction. But the question is, where can we target? What will be the areas that we can target when we want to do brain stimulation addiction? One of the areas that would be helpful to be able to find the targets are what we call brain lesion studies. There is a recent brain lesion study by Michael Fox and others in Harvard and kind of other teams that they showed that there are brain lesions that probably could be related to disrupting addictive behaviors, okay? This is something that people have done before, but in this specific study in Nature Medicine, they have been able to develop a large database of those who had brain lesion, and after having brain lesion, some of them, they stopped their addictive behaviors, and on some of them, they didn't stop their addictive behavior. And the question is there any chance that we can find the specific circuits that could be related to addictive behaviors? And what they did, the idea is if you have several patients that they have brain lesions and they have same symptoms, for example, they all have stopped smoking cigarette. They have been smokers, but they stopped smoking cigarette. And if we put all those brain lesions together, there should be one specific neuroanatomical substrate of stopping smoking cigarette. And we probably can find that. That is the idea of brain lesion studies. And that should be the common neuroanatomical substrate of that specific symptom that has been changed after the lesion that has happened. So based on the idea, they try to kind of compare those who stopped smoking cigarette compared to those who didn't quit smoking. And they try to see if they can find a specific kind of characteristics or a specific overlap between those lesions. After putting all those people together, they realized that there is no overlap between those two groups in terms of the brain areas that are involved in quitting smoking cigarette or continuing smoking cigarette. So they have not been able to find a specific area that would be shared between these two groups of basically between those who have lesion and they stop smoking cigarette. So that was something that they have not been able to find, which was pretty frustrating for them in terms, because there have been some smaller studies that they showed, for example, insula is important. So if we have lesion in insula, that could kind of help people to stop smoking cigarette. But they tried to see, okay, what could be the other explanation? So the idea was, okay, it seems that there are people who have same symptoms, but they have different brain areas involved on making that specific symptom. And the idea was okay, if those areas are not overlapping, they might be a part of the same network. So they are not overlapping to the same area, but they are part of the same network. And if we can do the analysis in the network level, we can find if they are part of the same network or not. So they tried to kind of redo the analysis within a network level analysis, and they found, yes, when they do network level analysis, they can find a specific network which is involved in stopping smoking cigarette. And this is the network that they found. I will discuss about that network and how that is going to be important for the discussion that we have today. The interesting thing is they have tried to replicate the same results in another database of alcohol users. And they have been able to show that that data, that basically map of being able to stop smoking cigarette could also be replicated in another large database of those who have been alcohol users and they had brain lesions. So they showed that that map could be consistent, not only in nicotine use disorder, but also to alcohol use disorder. And that was another strong sort of evidence that that map makes sense in terms of importance of that specific network in addictive behaviors. But my involvement with that study was quite interesting. I received an email from a reporter from New York Times before publication of this paper, and they have been looking for somebody to help them to understand the paper, because the paper was going to be published, for example, it was supposed to be published on Monday, and it seems that Nature released that paper to New York Times because they knew that's going to be a kind of an important kind of finding. And they have been looking for somebody to kind of help them to understand the paper and be able to kind of make a kind of report out of that. And I had several discussions with the reporter, and we ended up kind of being able to formulate what they had in the paper in a way that would be understandable for others. And it ended up to be a piece in New York Times. So if you search with my name and New York Times, you can find that piece. That is the piece that ended up in New York Times. But that basically motivated me to read the paper from A to Z. So this is something that usually these days is not happy in terms of you go and even read the supplemental parts. And these Nature Medicine papers are pretty long. So it was something like 40 pages. So I read the entire paper during the weekend. And it was quite interesting for me in terms of kind of reading all those details inside the paper and even finding some methodological details that I didn't like very much. And I was thinking, oh, they might need to change those methodological details. But the interesting part about the kind of the details they had inside the paper, I realized, okay, this is the brain lesion that they have, brain lesion map that they have. As you can see here in this map, I put that brain lesion map on a cortical surface, so you can see that's it, and mainly an area in the frontopolar part of the brain, which was involved on that neural circuit. I was thinking, that's an interesting area. Do I have activation on that area in brain Q reactivity maps that we already have? So I went back to the maps that I had, and I kind of tried to look into what we already have. And I saw, okay, that's interesting. It seems that we have activations there. So I put that cluster that they have on the cortical surface, and I realized, okay, it seems that there are some overlaps between what they report as the important area for brain lesions to stop addictive behaviors and the activations that we have in the brain for responses to drug-related cues. So I think that's interesting, and that area is an interesting area. And I knew that that area is quite interesting. So we started to discuss how we might be able to dig in more in details about how that area works in the brain. So I started the discussion with Ghazale, who's here, who's our new postdoc here in the department, in terms of how we might be able to do some extra analysis. And we saw that area, that basically cluster is highly connected to two major areas inside the brain. One is left amygdala, left medial amygdala, and also dorsolateral prefrontal cortex. And this is task-based connectivity. So this is the connectivity that is increased when people are exposed to drug-related cues compared to neutral cues. So it is a task-based, what they call PPI connectivity inside the brain with that specific cluster that we have. So I've been thinking that's an interesting kind of connection. And it started to ring me in terms of what are the other publications that we have with this specific kind of network. And we knew from before that people like kind of Brian Adinoff and Elliot Stein, they reported before that cortico-amygdala coupling is important for predicting relapse in cocaine users. And the interesting thing that they had in their findings was the connectivity between left centromedial amygdala and VMPFC is an important predictor of relapse. And the area that they call VMPFC is very much kind of overlapping with the area that we are discussing in terms of frontopolar cortex. So the area that they have is close to what we already have here. And even the kind of the left medial amygdala part is the same in terms of the connection that we have. So that's quite interesting. So let's move forward and see what we might be able to do in the next level. The other interesting thing that people reported in that specific Nature Medicine paper, we know that there are some recent studies with deep TMS. That's a kind of a specific form of TMS that we have a helmet that we put it over the head and we can stimulate deep parts of the brain. So there was a trial that recently published trial that they showed that if they do this kind of deep TMS treatment, there are people who don't like the term of deep TMS. They feel that deep TMS is not the right term, but I'm not going to discuss about that. But it's a kind of a technology that would provide kind of a stimulation in even deeper part of the brain, also in the cortical part of the brain. So what they did the stimulation once a day for 5 days per week for 4 weeks, for 3 weeks, and then one session per week for 2 weeks. But for the entire package of treatment, this is among nicotine users. So we are talking about those who are smokers. And they also had a provocative administration. Do we know what does it mean to have provocative administration? What is provocative administration?
I would assume that it means they activate a cue.
Exactly. So they provide these people with nicotine-related cues to activate areas that are involved in drug cue reactivity, because we know when we stimulate the brain, the areas that are already activated, they would have higher response to the stimulation. So, and they showed in another study, if they do not activate those brain networks, the response would be much lower. So they show that we need to have that provocation administration. And they are doing the same with OCD as well. And even in the OCD protocol, they need to have the Q exposure part to be able to activate those areas. And even in their FDA approval for OCD, that's a part of the FDA approval. So you cannot do the stimulation alone. You need to do the stimulation with Q exposure at the kind of that sort of sequence of events. And based on that, they show that there is a significant response in deep TMS with different sort of analysis. And they showed that even kind of the percent of a pop-up participant that they have been able to quit smoking, also the number of cigarettes they smoke per week was significantly lower in the group that they received deep TMS. And based on that, they received basically the first FDA approval for nicotine use disorder using these kind of deep TMS devices. The term is actually not approval, it's FDA clearance. And there are some reasons behind that, because they had some approvals before. When you have an approval, then the next thing would be clearance. So it's not going to be the name as approval. But it happened in July 2020. So that was the first time that FDA approved any application in the field of addiction for brain stimulation devices. Okay. If you ask me about the effect size of what they had, the effect size was close to what we have with things like varenicline or other medication, which is not that small, but it's something like a medium-sized effect size. So it is not a really large effect size. But they have been able to receive FDA approval. But the interesting part is when you do some extra analysis in terms of the H4 coil that they are using for smoking, what are the areas that would receive the highest level of stimulation with H4 coil? You can see that H4 coil is actually stimulating frontopolar cortex at the highest level. And if I just basically make an overlap between the brain lesion map that they reported and also the area that a specific coil is stimulating, they are overlapping. They are doing another study with alcohol. They have published some of the pieces of that, but they are even right now looking for receiving FDA approval through that process. But even with the H7 coil, which is being used in OCD as well, they are still stimulating frontopolar cortex to the highest level. So it seems that they are targeting the same neural substrate through that deep TMS coil, which is quite interesting in terms of the overlaps that we have.
And Hamid, when the smoking studies were first undertaken, why did they choose sort of why did they choose the deep coil, and what targets were they aiming for?
To be honest, the initial idea that they have been thinking that they are targeting insular cortex. That was the initial sort of justification and discussion that they had. This is something like a post hoc analysis that they realized it is true that kind of coil could reach to insular cortex, but the highest level of stimulation is actually happening in the frontopolar cortex, not insular cortex. So these are the secondary thoughts that are happening right now. And people are realizing that because there are some, I mean, those companies, they have some issues in terms of how they report how those coils are actually working. And now people are doing some secondary analysis and they realize this is not exactly what they have been thinking before. But this is quite interesting that those areas are overlapping. So I was thinking that's interesting that we have these are the kind of methamphetamine Q reactivity maps from my lab. And these are the maps that Michael Fox reported. So I contacted Mike and I told him that, okay, congratulations for your paper. That's a kind of nice paper. It seems that we have some overlaps with what you have in your lesion studies, in drug Q reactivity studies. And he was excited and he told me, okay, that's great. Let's kind of put those maps together and see how we might be able to find some overlap between the maps. Then I contacted Colin Hanlon, and I saw before some of the kind of results that she had in terms of she had some activation in the frontopolar cortex, and I asked her to basically send us her data for alcohol and smoking, and we realized that in alcohol and smoking they also have same sort of cluster in the frontopolar cortex, and we have been able to show that okay, it seems that these areas, the map that we have from the alcohol smoking is pretty much overlapping with the map that we have from other substances. And it's quite interesting that there are some differences, but there are some shared kind of substrates, which is quite interesting. So we have started to think about, okay, how we might be able to push that forward for the next level. There are some ongoing kind of conventional TMS studies that they target different parts of the brain, they target DLPFC, they target different areas. But one of the most successful area that has been shown to be able to kind of modulate drug craving is an area in kind of medial prefrontal cortex, which is actually the frontopolar cortex. So that is the area that Colin Hanlon mainly kind of uses in her trials. And this is kind of the modeling that we did for her kind of protocol, and we showed that her protocol is actually targeting frontopolar cortex as well. And then we have been thinking, okay, what about the other successful kind of stimulation protocols that they have shown that they have been able to modulate drug craving? And one of the areas that we use, one of the technology that we use is called transcranial electrical stimulation. The last one on the right side of the slide. For transcranial electrical stimulation, those who know transcranial electrical stimulation, that's a kind of a technology that we use kind of very limited amount of electrical current to stimulate different parts of the brain. And this is how it looks in my lab in terms of we put different electrodes and we try to target the specific areas in the brain with different versions of brain stimulation, okay? The good thing about this specific technology, transcranial electrical stimulation, is it's pretty inexpensive. So you already have one of the devices that one of the companies made. So they could be even in the shape of something like a headphone. So they can make electrodes in a way something like comms, and they can basically stimulate different parts of the brain based on where I put those comms, and they can control electricity in different parts of the setting. And it is being controlled by mobile app. So you can basically stimulate different parts with mobile app in different stations. So it could be pretty inexpensive in terms of the technology and how people can use the technology, okay? And we did a study among MET users to see how we might be able to modulate drug craving among MET users. We put the electrodes on the right DLPFC and left DLPFC with the idea to stimulate DLPFC and increase top-down regulation from DLPFC. And we showed that, yes, if we stimulate DLPFC right and left in MET users, we can decrease the level of craving that people would experience after the stimulation. But after that lesion study, I started to think about, okay, I mean, I have done some kind of modeling studies, and I know that when we do the stimulation on dorsolateral prefrontal cortex, the electrical current is not actually exactly under the electrode. So we did some extra analysis, and we showed that, yes, when we do the right DLPFC, left DLPFC electrode montage, the highest level of electrical current would actually be in the frontopolar cortex, not in the DLPFC area. So we are also targeting frontopolar cortex with that specific electrical stimulation montage, which is also converging to what we have been thinking about other stimulation technologies. The major challenge that we face in electrical stimulation studies is what you can see in this slide, in terms of there's a significant level of inter-individual variation in terms of the amount of electrical current that we can deliver inside the brain. Because the skull is really different. When you put the electrodes in over the cortex, there are people who would receive significant amount of electricity in the frontopolar cortex that I have been mentioning, but there are people who do not receive significant amount of electricity with the same level of electrical current. So, and the responses are pretty different. And we showed in another study that, if I have the slides, yes, that the level of electrical current in the frontopolar area would be predicting the response to TES, not level of electrical current in other parts of the brain, which was encouraging. And this is something that we published before, something like 2019. So it is something that is converging with what we are seeing right now in the brain lesion study. So the question is there any chance that we can go to a better level and do individualized electrical stimulation? Okay, so that is what I'm trying to show you in the remaining part of the presentation. I'm going to kind of sit down now and try to see how I can speed up the presentation and just give you some another ideas in terms of how we might be able to do some individualization. Okay. To be able to go for individualization, we need to have lots of data from the previous trials. And the area that we have in psychiatry that we have highest level of data is depression, because in depression, TMS received approval in 2008. So since 2008, people have done lots of trials, so they have been able to collect lots of data to be able to do secondary analysis. So in the field of TMS, people have tried to see why there are people who have been responsive to TMS depression and why there are people who are not responsive. And is there any chance that we can find why would be the reason for being responsive to treatment or not? So one of the recent findings that people realized over time, they realized that if they measure the clinical improvement, here, the clinical improvement is measured in figure D, is measured by the percent of change in Beck depression inventory, okay? So if they measure how much people are responding to TMS based on the Beck depression inventory measure, and another measure which shows the level of connection between the area that we are stimulating and subgenual cingulate cortex. So if they measure the connectivity between subgenual cingulate cortex and what we have in the LPFC, those who receive the stimulation in an area that has higher negative connectivity to subgenual cingulate cortex, they would have highest treatment response. So it means that the highest subgenual connectivity, the lower subgenual connectivity, as you can see here in this kind of, in the x-axis, would be associated with the higher treatment response. And they realized that probably the best point to stimulate would be finding for each individual what would be the area that would have the lowest or the highest negative connectivity between the area on the prefrontal cortex and subgenual cingulate cortex. And we know from the field of kind of affective neuroscience that subgenual cingulate cortex is important for affective processing and depression and all those things. And if it is negatively connected, probably when you stimulate that area, we would have highest suppression on that area. So that was the kind of the basic idea of doing that. And based on that, they developed a specific trial, which is called Stanford Neuromodulation Therapy. I'm sure most of the people have heard about this trial. And they showed that in this trial, that if they do individualized brain stimulation, so they define the target for each individual patient. So instead of just doing one size fits all that they have been doing before on DLPFC, now they are doing for each individual patient, they find a specific area that should be targeted and they try to target that area. There are some other aspects of some other new aspects in that specific treatment. One of the things that they did, instead of just doing one session per day, they did 10 sessions per day and compressed the entire 4-6 weeks of treatment into just 5 days. So they do it in an outpatient setting. The patient comes 8 a.m. until 5 p.m. They receive 10 sessions of TMS per day in 5 days. But in just 1 week, they showed that there would be a significant drop in kind of MADRS score, and that response would stay, kind of still stay there for quite a long time, for several weeks, which was pretty kind of robust. And the treatment response was something like 78%. And their kind of effect size was really large. So it was kind of a really interesting study. The problem is the control condition has lots of differences with the active condition. So it is hard to say whether it is just the individualization or other aspects of the things that they are different between these two arms are contributing to that. So it is really hard to say that individualization is the only factor that is contributing, but that could be one of the reasons that is contributing to the better response. So as you can imagine, it is a Stanford, and what they do, you usually kind of try to make a patent out of that and make a company, and that is a new company. It's called Magnus Medical, and you probably heard that FDA kind of gave them a new approval for that specific patented protocol. And there are some kind of technical details in terms of how they have been able to patent that connectivity between subgenual cingulate cortex and DLPFC to be able to make it in a way that they can just do it in their own company, not other companies. And there are some politics behind that, so I'm not going to get to those politics. But the interesting part is any chance that we can use the same idea in the field of addiction in terms of doing individualized frontopolar stimulation to make most of it in terms of the treatment response if you want to modulate drug craving. And based on what I showed, we started to think about, okay, how we might be able to make that happen. We realized that, okay, it seems that the connectivity between frontopolar cortex and amygdala is important. But the question is how we might be able to develop an individualized protocol for stimulating that. And does individualization make a difference or not? So that is the question that we have started to think about. First of all, it might be interesting that even if we evaluate the level of response in different parts of the brain to drug-related cues, left medial amygdala would have the highest response to drug-related cues. So this is the kind of the bar charts of different. So this the green area has the highest level of response. And we started to kind of see, okay, if we consider that amygdala, left medial amygdala ROI or mask, and just see how that area is connected to other parts of the brain, the major area that this area is connected is the frontopolar and ventromedial prefrontal cortex. And we started to think with Ghazaleh in terms of how we might be able to develop how much people are different in terms of the connectivity between amygdala and frontopolar cortex. Do we have significant inter-individual variations or not? Or how people are different? So we did an individualized analysis, and we showed that, yes, there is a significant variation among different people in terms of what would be the area that has highest connectivity in frontopolar cortex to left medial amygdala. And we started to think, okay, it seems that, as you can see here, this is the XY axis. So you can see that these are in millimeters. So there is a significant variation in terms of, and each of those dots are one single patient. So this is 60 patients that we kind of evaluated how much they are going to be different from each other in XYZ kind of space within the frontopolar cortex. And we showed that the level of individual connectivity to frontopolar cortex would be correlated with the level of craving that they experience. So there is an like behavior imaging kind of correlation, at least to that level that we have here. So we started to think, okay, how we might be able to optimize the placement of the coil over the cortex in a way to consider that inter-individual variation, with considering only location or orientation of the coil, and also intensity of the stimulation. And we showed that with the kind of a new pipeline that we recently developed, we showed that we can optimize the stimulation in a way that people would receive the same level of electrical current on that area in a way that they would have the same kind of level of stimulation within the wide range of kind of spatial distribution that we have for the hotspots that we have for the stimulation. So it seems that technically it is doable to make that happen. And this is the kind of a new piece that we are putting together. This is the kind of the new pipeline that we have for individualization of the stimulation. And we are extending that pipeline. And I recently kind of submitted something like a short proposal for Sophia in terms of the idea that we have, seeing how we might be able to encourage Sophia to support us for a pilot grant to make that happen. So we'll see how we have been successful on that side. But now, just last part of my presentation, I'm also going to discuss a little bit about the other area that we discussed in terms of the DLPFC side. It seems that the DLPFC is also an interesting side for the stimulation. There are multiple studies that they show that probably DLPFC could be another target for stimulation in addiction. And as you can see here, even in this kind of the results that we have, DLPFC is another area for be considered as targeting area. And people have shown that before in terms of DLPFC has always been important area for top-down modulation. So executive control network over all those kind of affective salience network and default mode network. And this is what we know from before in terms of the top-down regulation. But it might be interesting that I've recently kind of done some extra analysis in terms of how DLPFC interacts with frontopolar ventromedial prefrontal cortex and amygdala in terms of processing drug craving. This is a new kind of DCM analysis that we showed that the craving would have significant input to amygdala, but there is an inhibitory control from DLPFC to the connectivity between frontopolar cortex and amygdala. So that is kind of a neural substance that how it basically drives the control. But the interesting new thing that we have recently added to that, we made what we call this dynamic DCM analysis. In dynamic DCM analysis, we show that, okay, if we expose people to the first series of cues and the second series of cues and third series of cues, if we expose people over the time, how those connectivities would be different over the time. The interesting part is the amount of craving input to amygdala would be increasing over a time, significantly increasing over time. And the level of top-down regulation that we have from DLPFC to VMPFC amygdala connectivity would be decreasing over time consistently. So it shows that when you expose people to draw cues, first cue, second cue, third cue, so it just basically you decrease the level of control that we have. And that is something that is important in terms of how we get to a level of relapsing and having problem with substance use. So there's another kind of support in terms of DLPFC is important. But whenever we talk about DLPFC, it's important to mention that we also have a parietal node, which is contributing with DLPFC as executive control network. An executive control network could be another target in terms of improving executive control network to modulate drug craving. To be able to do that, we have another type of electrical stimulation we call transcranial alternating current stimulation to be able to engage frontoparietal connectivity. And this is another kind of line of research that we are pushing forward to be able to increase activations and response in frontopolar, kind of executive control network. But to be able to do that, we are doing some other kind of new analysis in terms of how we can engage those networks in the brain. But interestingly, we recently found that frontoparietal cortex, as we know by F3, P3, F4, P4, is not actually involved in drug cue reactivity. And that was a little bit frustrating. So we have been thinking, I mean, that's in the literature that whenever you have exposure to drug-related cues, we need to have executive control network being involved, and we need to have connection between F3, P3 and F4, P4. But we didn't find that connectivity. That was pretty kind of frustrating. We have been exploring what was the problem, and we did something like a whole brain analysis, considering the frontal side as the main seed and connection to other parts of the brain. And we realized, yes, there is a cluster in parietal cortex, which is involved in connectivity with the DLPFC part, but is not actually under P3, P4 electrode. So we realized if we want to stimulate that area, we need to change the montage to what we call CP5, CP6. And we need to optimize that montage selection. So that we basically optimize that montage, and with optimized montage, we saw that yes, there are significant connectivity between frontal part and parietal part. And that's the network that we are interested to explore. This is a new pipeline that we developed to kind of do the stimulation of that network. And now we are interested to see how we might be able to optimize that stimulation now in the individual level. To be able to do that, we are right now trying to put that inside the scanner. So we usually kind of use watermelon as the first step to do the stimulation, and kind of putting the electrodes over the watermelon and putting them inside the scanner. And as you can see here, we can see inside the watermelon and the things that you can see inside, even the quality of watermelon. You can just do MRI and see how is the quality inside the watermelon. And of course, after the stimulation, we just open the watermelon and yeah, you just eat the watermelon as the fun part of the but we eat that as well. So that's a kind of, yeah, pretty creepy, but yeah, but just but yeah, that is something that we can do with watermelons. After watermelon, the next thing that we put inside the scanner is, of course, the PI of the project would go inside the scanner and receive the stimulation. And this is what we kind of show that it is technically doable, and we can engage that frontoparietal network. That is the setting that we developed when I was working at Laureate Institute for Brain Research with 2 brilliant postdocs. And we showed that, okay, it seems that we can do the stimulation inside the scanner, we control the noise and everything. And then we started to think, okay, now we can do the stimulation inside the scanner. Is there any chance that we can define a specific target in each individual and then define what would be the optimized engagement that we really like to have in that network, and then just close the loop? So stimulating inside the scanner, recording the connectivity, and then optimizing the stimulation parameters. Because in the stimulation parameters, we can change the frequency, we can change the phase differences between two nodes. So there are multiple factors that we can change in the stimulation in an individual level. So we started to what we call closed loop TS-fMRI, and this is another level that we are doing. We have recently finished collecting data for 20 subjects with the same protocol, and we put that together, a recent piece that has just been published a few weeks ago on real-time closed loop TS-fMRI and the feasibility of that. And there is no other lab in the world that has done that in that level that we have done, and we are really hopeful to be able to expand that. Right now, we are working with people in CMR, and we got funded specifically for that line of research, and we are trying to kind of push that forward. And we hired Ghazale as the postdoc for that project, and we are hopeful to be able to collect some data here in University of Minnesota. So just kind of some wrap up things. Those who are interested to know more about that, we had a specific webinar with group of people that we put together that kind of those discussions, and that webinar is already available online on YouTube about personalized non-invasive brain stimulation for addiction. The other thing that might be interesting, that till the end of 2022, we have over 200 published trials with addiction and electrical stimulation and TMS. So the field is expanding. As you can see here, there is a kind of a small ditch here because of the pandemic and things related to pandemic, but the field is expanding. So people are getting more and more excited about the future of the field. And there are some ongoing FDA applications for alcohol, for cocaine. So people are expanding that area and potentials for new research in the field. But it might be interesting that if you distribute the publication across the world, US is not the only country which is contributing to the field. So there are many other countries who are contributing. So we developed what we call international network of TS-TMS trials, trying to collaborate together and how we might be able to do things together. And we publish a paper, a consensus or white paper on what are the quality standards of running trials in the field. And this is a piece that has been recently it has received significant amount of citations over the time. And we are trying to push that a specific network of collaborations in the field. Those who are interested to know more about neuroscience and how neuroscience could inform treatments for addiction, that's the kind of a textbook that I put together with Martin Paulos, and we are hopeful to have the second edition within the next 2 years. And as you can imagine, that is kind of the excitement that we have in terms of changing the future of psychiatry and with MRI and brain stimulation. And we know there are lots of limitations. So we are not going to just make a hype over that, but we are hopeful that with all the things that I discussed today, there would be some interesting future for the field. So take home notes, trying to wrap up. First of all, the QR code would give you the slide. So if you like to have the slide, you can have the QR code. And today, I think I try to give you an idea about what is TES and TMS. So at least now you have a better sense how those technologies might be helpful. And going back to the question regarding how many FDA approvals we have for non-invasive brain stimulation psychiatry, these are the areas that we have: MDD, OCD, smoking, and there is one on anxiety comorbid with MDD, which is for the same company of BrainsWave, which is making those deep TMS coils. And there are 2 other approvals that are not really kind of psychiatry, but cortical mapping, migraine. These are 2 other areas that they receive FDA approvals. And this is the timeline of those approvals over the time. The first one was 2008, but over the time, different companies, they received approvals for different applications. You can see underneath the application they received FDA approval with different companies. And even for depression, I mean, there are multiple companies that they receive approval for their devices now. The field is expanding. So today we talked about cue-induced craving and the importance of cue-induced craving in relapse, and an importance of cue-induced craving for preparing people for the stimulation protocols. We talked about growing body of evidence with trials in the field, and we discussed about the stimulation targets, different targets that could be stimulated for the field of addiction. And we discussed about how, I mean, different networks in the brain could have some overlap between different substances. And we showed the different successful trials that they showed they can modulate drug craving. All of them, they are targeting the same area in frontopolar cortex. So it seems that frontopolar cortex is an important piece. So we put together a review with Michael Fox and others who have been contributing to this discussion, and we submitted that for American Journal of Psychiatry. And just a few days ago, we received a reasonable review, and the editor liked the paper. So fingers crossed, we are working. And there are some reviewers that, I mean, they made some kind of strong points, but we are working on that. So at least we received the review. So that is the thing that we received so far. So hopefully we can push forward for the next step. And we have discussed about large inter-individual variability, how we might be able to consider large inter-individual variability. We discussed how structural MRI and fMRI could inform stimulation parameters, and we discussed how that could be happening in the individual level and how that could be the next steps. And then what would be the future of interventional or precision psychiatry with those individualized protocols, which is quite exciting for us. But at the end, I'm also interested to mention that I'm always interested not only discussing about the technologies, also how we can communicate the importance of those technologies, or how those technologies are working with the patients. Even the cartoon that you can see here on the side, this is the cartoon that I made with the cartoonist. So we have been discussing about how to communicate those technologies with people, and trying to make cartoons to help people understand how their brain would recover from psychiatric disorders, and how they might be able to take strategies, even simple strategies, to help their brain in the process of recovery. And we already have, I mean, we developed those cartoons, and now we have them in different languages. This one is in Hindi, and people around the world, they translated in different psychiatric departments. Now we have them on 22 languages so far. So we are trying to kind of expand those activities as well. And I'm really hopeful that we can also do some networking activities with people who are active in the field. And we are developing what we call international network of neuromodulation, neuroimaging, because we believe that now we need to use neuromodulation, neuroimaging to inform neuromodulation in the individual level. And that's a network that we have. Those who are attending SOBP, we will have a panel in SOBP discussing about some of the recent work that we are doing. We have some activities in OHPM. We are putting together a group in ISMRM. We will have a webinar next week, Thursday, discussing about precision function mapping for individualized neuromodulation with some like 12 speakers, and we will discuss about some of those things that we discussed today in different areas of psychiatry. If you are interested, you can join us on that webinar. And the last slide. Before kind of finishing my talk, I would like to kind of thank again those who supported me to be here. And Anna was one of the first people who basically encouraged me to apply for residency here. And she kind of encouraged me in terms of the really nice people who are working here. And then Sophia for her support in terms of kind of, even from the first email, I realized that, oh, it's just amazing to have a chair like Sophia supporting and putting people together and encouraging people to do greater stuff. And then Ziad for his support. I mean, in many different aspects of what I'm doing right now. Kelvin for, I mean, unbelievable support. Right now he's in his sabbatical, and I think every night we exchange an email. I was thinking, oh, I'm feeling guilty. You are on sabbatical, but we are still exchanging lots of emails. And I mean, many thanks to Kelvin for his support, and Mark Thomas for the funding that he provided, and other encouragement and other supports that he's providing through MDTA, and many thanks to those people. And what I'm trying to do in the next 2-3 years, I'm thinking to do two main kind of things beyond what we have done so far. First of all, I'm moving forward to be able to use, to get to a level of quality to convince FDA to accept drug Q reactivity as a targeting biomarker. So that is one thing that I'm trying to do through their biomarker qualification pathway. And to be able to do that, I need to have a larger database. And I started to contact anybody around the world who has drug Q reactivity databases. And there are, till yesterday, we have 421 publications with fMRI drug Q reactivity. So I contacted all those labs. We are working, and with Anna, we are trying to see how we might be able to bring those pieces of data. Right now, we are working with Enigma on that, and we are hopeful to be able to get to a quality level to apply for FDA qualification package for fMRI drug Q reactivity as a biomarker. So that's one line of research and work, and there are lots of things that we need to do on that side. The other thing I'm interested to expand is basically trying to how we might be able to do individualized targeting for frontopolar stimulation. And I'm working with Christine Cornelia in terms of how we can use the robotic arm TMS that we have here in MIDB to do the stimulation. So we are working together, making sure that that protocol is going to be technically doable, and we are trying to push that forward. And this is finally my last slide. Thank you very much for your attention. And sorry that was such a long talk with 110 slides. And thank you very much for your attention.
Hamid, I have a question. Well, maybe you'll monitor Q&A.
Yeah, absolutely. Thank you so much, Hamid. What wonderful talk.
Yeah.
Sophia, you had a question?
Tour de force.
Yes.
So, you put your sort of two main kind of directions of your research now, but it seems the two are quite interactive, because presumably Q reactivity, right, being able to sort of look at individualized Q reactivity patterns of activation is going to be part of your targeting, right?
Absolutely.
Of your individualized targeting, yeah.
Yeah, they are basically feeding each other.
Yeah.
That is, and then if we can, because there is always a question in terms of, okay, if we have a brain activation, is it a real deal or is just a paraphenomenon?
Right.
So, and if we can do the stimulation on that specific area and see if there is a significant response in behavioral side, then we can just basically support that, okay, that is the area that we actually need to do a stimulation.
Mm-hmm.
So I think that both sides would support each other at the end of the day.
One of the questions that comes up for me, I mean, it takes a long time. Well, there are parts of it that can happen quickly, but really to become an addict takes a while, right? So there are these long-term plastic changes in the brain. Now you're coming, so you've identified some of the circuits that are involved in these plastic changes that are, in a sense, driving the maladaptive behavior. And now you're coming in with a stimulation technique to sort of tweak those circuits a little bit so that, for example, there's not as much Q reactivity. And yet, what, in a sense, you alluded to it, right? How durable is that? What other changes throughout distributed networks, not just that particular circuit, need to occur for the person to sustain complex changes in their behavioral patterns that either help them manage Q reactivity when it occurs better than they've been able to manage it, and or to avoid the places where Q reactivity is going to happen, et cetera. So it seems to me that the next step eventually in the research is going to be not just how do we short-term manipulate this particular circuit, but how do manipulations of this particular circuit then need to be embedded in sort of longer-term, embedded in ways that drive longer-term, enduring, more complex behavioral changes. I would assume, yes. You're nodding, so you're thinking the same way.
Absolutely, that's a brilliant question, and I totally agree that we are talking about really profound brain changes over significant amount of time, and we know that kind of neuromodulation is not going to change everything in one day. So we know that there are challenges. There are some kind of aspects of neuromodulation that I really like about this discussion that we already have. When we talk about drug addiction, when I talk with drug users, sometimes they tell me that the reason that I relapsed was an episode of having intensive level of craving, 4 a.m. in the morning, that I was not able to call my sponsor, and I had significant level of craving in a way that I was disabled, and I had to just jump into my car, find the first liquor store, and just buy a bottle of liquor to be able to control my craving. And if there was a tool that was able to help me to control my craving or reduce my craving for 10 minutes, then I probably would be able to save my sobriety and not to relapse. So that is the reason I'm thinking about these sort of technologies. If we can make a portable device a way to be able to target the network in the brain, and it would be a home use device that people can have, even if the effect is just temporary, if even the effect is just for a few minutes, and even if the effect is just online, the effect would be there when you stimulate the network. Whenever you stop a stimulation, the effect will be gone. I'm fine with that. Then I can control craving for 10 minutes. That would save lives. So I think that even that level of modulation, and that is the case for things like other suicidal ideations as well. I mean, there are some other areas that if we stop the active, ongoing cognitive process for a few minutes, we can save lives. So I'm hopeful that with the technology that we are using, with the kind of individualization, we can get to that level. Even I kind of receive sometimes the question from people who kind of review our closed loop FFTs, fMRI kind of publications. They say, okay, that is too expensive. I mean, you need to put people inside the scanner, do the closed loop stimulation, find how that network, and then finding the engaged network. Okay, how that's going to work at the end of the day in the kind of the real life? My hope is if we can do the closed loop, if we can do the stimulation, if we can engage the network, then I might be able to use that optimized protocol outside the scanner with a home-based device to use the same frequency, phase, whatever protocol that they have, to be able to help them to control the drug craving 4 a.m. in the morning, 2 a.m. in the morning. So that is the hope that they have. And to be honest, I'm pretty much hopeful that within the next 20, 30 years of my career, I'm going to make that happen. So that is what I'm really hopeful to be able to happen. And I feel that is technically doable. Or at least I can kind of educate the next level kind of group of postdocs that they can follow that. Maybe after my life, they can make that happen. But I'm pretty confident that it's going to happen.
I have a couple of questions, Hamid. Wonderful talk. Have you done any sort of real-time neurofeedback in the scanner using that device? I thought that Anna had told me that you had done some neurofeedback.
Yeah, what we do, I mean, the trial that I showed you, we did that for 20 participants in terms of putting them inside the scanner and do the stimulation recording inside the scanner. This is what we did with healthy participants.
Yeah.
That is what we did. Now we just submitted an IRB application, which, I mean, we received the revision, and we are working on the revision part. But we are trying to do that inside the scanner here with Met users. So, but this is still a pilot stuff. So we are trying to see if we can engage the network.
And then I'm gonna steal one more question really quick. It's kind of a bigger question. You know, I know that there's a lot of enthusiasm and that your talk really was about sort of this individualized precision targeting of networks that are involved in substance use. There's also a literature that talks a little bit about how neuromodulation also impacts sort of just general inhibitory excitatory tone. And I feel like that sort of aspect of neuromodulation sort of is de-emphasized these days because I think we're very interested in sort of this precision targeting. How do you sort of account for those types of changes or sort of incorporate that into how you're conceptualizing how these treatments might be working?
I totally agree that we are, I mean, when we talk about the stimulation, we are talking a wide range of different things that are happening. Even when we talk about the stimulation, we are not only stimulating the neural components, we are stimulating glial cells. We are stimulating vascular system in the brain. We know that we have a huge vascular system in the brain. So we are doing lots of different things inside the brain. And it's really hard to see how they are working. And even the kind of the individualized stimulation that we are discussing about with the devices that we have, we always have a discussion with Ghazali in terms of, I mean, how much the individualized protocol is going to matter in terms of the engaging that network. Because even the TMS machine that we are using, they are stimulating quite a large part of the brain. Yeah. So we are stimulating something like a box of 2 centimeter to 2 centimeter to 2 centimeter. So it's a pretty kind of large voxel that we are stimulating. So we are not talking about a voxel of really small size. So we are stimulating large parts of the brain. With the electrical stimulation, we are even stimulating larger parts of the brain. So it's still an ongoing discussion in terms of how much being focused is going to be helpful. And there are even studies right now, they show that sometimes even using the non-navigational system, non-navigational systems would give us this opportunity to just be right at the same spot for every single session that we have. They showed that using neuromodulation with non-navigation could even diminish some of the effects that we have. Why? The idea is when we do a stimulation by hand, there would be a significant amount of wiggling around. So you stimulate different parts. When you do the neural navigation with the robotic arm, you are on the same spot all the time. So you might miss some of the kind of the areas that you might be able to stimulate. So this is an ongoing discussion. So I'm not quite sure how, and especially when we do things without a specific targeting, we just try to modulate things in the larger scale. But I'm really hopeful that we kind of individualized, targeted stimulation, we can even kind of, for example, when we do ECT, there are lots of really good things, but we know that there are some side effects. Meanwhile, it's always a discussion in terms of, okay, when we have memory loss, sometimes people realize that the level of electrical current that you give to each individual that would actually penetrate to hippocampus would be a predictor of response to TMS. So we know that, that level of current could make side effects, but is it really side effects or is it the actual effect that we are kind of delivering? So
I know it's always just an interesting question that I think about.